This video is all about antiplatelets and anticoagulants. So the first thing to understand these medications is to understand the steps the body is taking to try and form a blood clot and basically how that happens. And then we can understand which steps along this process that the medications stop. So the first step to a clot being formed is vessel injury. And the body wants to get from vessel injury all the way to forming a fibrin mesh, which is a stable clot. So vessel injury is one of the risk factors for getting a blood clot, and we'll call that endothelial injury. The endothelium is the inner layer of blood vessels. And as we'll come to learn, damage to the inner layer of blood vessels exposes some factors that start this process. There's other things that make us more likely to form a blood clot. Another one is hypercoagulability. So we literally have more ingredients, the ingredients that it takes to form a blood clot, we literally have more of those floating around. And another factor is venous stasis, blood sitting still. So there's all sorts of processes that add up to having any one or multiple factors. Endothelial injury, for example, atherosclerosis. So plaque is building up and damaging the endothelium over time. Smoking, chronic irritation of the inner layer of blood vessels, infection, sepsis. So lots of inflammatory mediators floating around, damaging the endothelium. Hypertension, so many things that you would not expect causing endothelial injury. Constant high pressure, causing a shear stress. And then, of course, trauma. And that could be accidental or intentional. Any kind of tissue injury. So getting an IV line placed, having surgery. And then, of course, it can be accidental trauma too. And anything that's, let's say, increases inflammation. Because inflammation damages the inner layer of blood vessels. Another good example, hyperglycemia, the type that comes along with especially type 2 diabetes, but type 1 diabetes too. High blood sugar damages endothelial cells. So there's just a few examples you're going to see in clinical practice of people that have endothelial injuries. Now, how about hypercoagulability? Well, nature made pregnant women a little bit more hypercoagulable than the average person. The reason for that is to protect against hemorrhage during delivery. Estrogen exposure. So oral contraceptives, for example, you're going to get increased clotting factors from increased estrogen. Of course, anything genetic. Cancer situations. Tumors can actually release procoagulative substances. And we can have infection or sepsis here as well. So these are the kinds of patients that you're going to see that are hypercoagulable. Now, venous stasis. So normally blood is flowing in a smooth, continuous flow. But when it becomes slowed down or sluggish, or it's not flowing like it should, like with immobility, so literally just not moving as much as you normally do. People on bed rest, post-op, post-surgery patients, long travel, being on an airplane for a long time, heart failure. I'll just go heart failure. So the number one job of the heart is to propel blood forward, whether it be to the lungs or to the systemic circulation. If it can't do that, blood is going to back up. You're going to get edema. You're going to get venous congestion. Another cardiac reason, atrial fibrillation. So you've lost the atrial kick. So my left atrium is not kicking blood into the left ventricle anymore because I have a disorganized atrial response. So some blood ends up kind of sitting around in the left atrium. That's why people who have AFib are anticoagulated. So these three things are called Virchow's triad. So when you hear the phrase Virchow's triad, they are talking about those three things, and any one of them or more than one of them together makes you more likely to form a blood clot. This is why you will see patients that are immobile after surgery on anticoagulants. In this video, we're going to focus mostly on the vessel injury. So what happens inside a vessel when a blood clot is going to form. So I'll take you through step by step what the platelets are doing and what normally happens, and then we'll go through the medications that disrupt each step. Okay, so let's draw out a vessel injury so that we know exactly what's happening. Here's the inner layer of my blood vessel. Here's the endothelium. And I've had some sort of break in the continuity of the vessel. I've had an accident or a trauma or something like that. So I'm on the inside of a blood vessel and I have blood flowing through. When the endothelium is damaged, collagen gets exposed. Normally it's hidden inside the walls of the blood vessels, but here it is exposed because of the damage. It also exposes, so I'll put that in blue, there's the collagen. Vessel damage also exposes something called von Willebrand's factor. And I'll put that in green, so it exposes von Willebrand's factor. And this is also floating around in our bloodstream as well. So we have collagen, we have von Willebrand's factor, and we have platelets floating around. So how do we get all these three things together? Well, I'll zoom in on this picture. So I have my exposed collagen. What von Willebrand's factor actually does is it creates a connection between the platelets and the collagen. So it helps platelets stick to collagen, and that's what adhesion is. It's platelets sticking to collagen. So I'm going to go back up underneath vessel injury. And so after vessel injury, first thing that happens is, well, one of the first things is von Willebrand's factor is released. And of course, we have exposed collagen. When you have those things and you have enough platelets floating around, what's going to happen is that you're going to have adhesion, platelets sticking together. So I'll write that here, platelets. Actually, I should be more clear. The platelets aren't sticking together yet. They're sticking to the wall, the vessel wall. They're adhering to the damaged vessel wall. And von Willebrand's factor acts as the connector and makes that happen. The next thing the body wants to do in this series of steps to get to a stable clot is to activate the platelets. So we're on step number 2. The platelets are adhered to the wall. Now we want to activate them. And activate means turn them on. Basically switch from a resting state to a clot forming state to turn the switch on. So let's say we have a platelet right here, and this one is attached to the exposed collagen through von Willebrand's factor. So there's the von Willebrand's factor, the connector, and here's the collagen that's sitting there exposed because of the damage. So this platelet number 1, this one is already activated, and it got activated basically through this connection. So it is in the clot forming state. It's ready to make a blood clot. It's activated. Well, the other thing that it wants to do is activate other platelets, ones that are floating by. It wants them to stick together, and it wants to turn them on as well. So we'll call this platelet number 2. So platelet number 1, just like all platelets, has a substance inside it called COX-1. When the platelet gets activated, COX-1 works on a substance called arachidonic acid. And from that, a substance called thromboxane A2 is created. So when this platelet is activated by the adhesion, that's when COX-1 knows to start this process to create thromboxane A2 and to release thromboxane A2. So remember, platelet number 1 has already been activated. That activation also tells it to release a substance that it has inside of it called ADP. So ADP is also released when it's activated. These two substances are the workers that travel along and activate platelet number 2. So ADP is going to bind to this receptor and activate platelet number 2. And TXA is going to bind to this receptor and activate number 2. Well, now this platelet is going to create TXA2 and ADP, and it's going to be very motivated to bind to this platelet, and it's going to release these substances, and that's going to go to platelet number 3, and on it goes. And now we have all sorts of platelets activating and all sorts of platelets adhering to this exposed collagen site. And that's what activation is. And so just in very simple words, we can call activation platelets sticking to each other and sending signals to other platelets to stick to each other. So I'll erase this for now, but when we talk about the drugs, I'll come back to that drawing. So step 2 activation, platelets sticking to each other. And I'll put platelets activating. And I'll just put others, because an activated platelet activates other platelets. And I'm going to draw a line from exposed collagen to step number 2, because that's one of the things that triggers the activation is the exposed collagen. So just to be clear, von Willebrand release and exposed collagen cause step number 1 adhesion. And exposed collagen also plays a role in activation. Okay, now we're on step number 3. And on step number 3, we actually make use of a substance that's already floating around, and it's called fibrinogen. But I'll show you how we make use of it. So here's my platelet number 1. And we know it started to adhere to the vessel wall. And we know it released TXA2. And we know it released ADP. It's activated. And we know that it activated platelet number 2 because these substances went along and bound to these receptors and turned on this next platelet, which is in turn going to make its own ADP, or I should say release its own ADP, and make and release its own TXA2. So that's what happened during activation. Well, when platelet number 1 releases ADP and TXA2, it impacts platelet number 2 a different way. And it actually makes platelet number 2 turn on what's called a receptor complex. So I'll draw it like that. And the receptor complex is called GP2B3A. So that is turned on. Like I said, we have fibrinogen floating around in our bloodstream. And when this receptor complex is turned on, that's where fibrinogen likes to bind. And now let's say we have platelet number 3 floating around, and this guy got activated too, so he has this receptor complex as well. And those receptors like to bind fibrinogen, and they bind the fibrinogen that's already connected to number 2. So now number 2 and number 3 are bound together, and on it goes. So that's what aggregation is. it's platelets sticking closer together through the action of fibrinogen. So I like to imagine it like a lasso around these platelets. They're already sticking together, but now they're sticking together even a little bit extra. Fibrinogen connects platelets. So we'll erase that. And I'll write down connects platelets. They were already sticking together, but now they're really connected. Okay, so that's step number 3. Step number 4, you're going to see the word fibrin. And I'm going to draw a connection between fibrinogen and fibrin, because fibrinogen turns into fibrin through the action of a substance called thrombin. And you might wonder, how do we get thrombin? Well, we get thrombin through the clotting cascade. So if you've ever seen in your textbook or read about the clotting cascade, here's where it comes in our quest to make a stable clot. The clotting cascade turns fibrinogen into fibrin through the action of thrombin. And fibrin, if we imagine all our platelets are now stuck together, they're aggregated together. Fibrin actually forms a mesh that really stabilizes this clot. And that's a very simplified version of the clotting cascade that I just put a picture of, and where different drugs work in the clotting cascade. And we'll come back to that when we talk about drugs. But the clotting cascade uses thrombin to turn fibrinogen into fibrin. And fibrin is a protein that stabilizes the clot. And now we're at step number 5, retraction. So platelets actually contain actin and myosin, just like muscle cells do. So basically they can pull closer together, and it's going to pull the edges of the wound closer together. And the body does that to basically reduce the bleeding. Fluid gets squeezed out, so serum is pushed out of the clot. It's going to look smaller and firmer. So the clot tightens itself. Okay, so that's a step-by-step of what is happening when a blood clot forms and how we get from vessel injury to a stable clot. And now let's talk about some of the medications that we're going to see. And actually now is a good time to review all this, because I'm going to need another diagram to review it. So we've had vessel injury. We've had collagen exposure. We've had von Willebrands coming in to help us out. We've had adhesion, and we'll call this one platelet number 1. And this platelet is activated. It became activated when it adhered through von Willebrands and through exposure to collagen. So this activated platelet uses COX-1 to create arachidonic acid, and uses that to make TXA2, thromboxane A2. And it releases TXA2, and it releases a substance that it already had inside of it called ADP. Here we have our second platelet floating around. This platelet has receptors on it, and TXA2 and ADP bind to these receptors, and now platelet number 2 is activated, and now it's going to release its own TXA2 and its own ADP, and of course it's going to connect to platelet number 1. Well, the other action, or the other thing that happens when a platelet gets activated, and I'll give us a little bit more room here, is a receptor complex turns on. So I'll draw it over on this side. Receptor complex gets turned on, and it's called GP2B3A. And that receptor complex binds fibrinogen that's already floating around. And then when we have another activated platelet come by that has that receptor complex also turned on, so we'll call this platelet number 3, they all start joining together. So that's just a step-by-step of what we just went through. Steps 1, 2, and 3. So there's medications that work in each of these steps. You are not going to see very many meds that work in step number 1, adhesion. What you are more likely to see in clinical practice is actually a disorder. It's called von Willebrand's disease. It's an inherited bleeding disorder. You don't have enough von Willebrand's factor. So I'll highlight that in yellow. Not likely to see a medication that impacts that step. Well, let's go to activation. There are medications that impact this step. There's a non-steroidal anti-inflammatory. Another class for it is an anti-platelet, and it's ASA. So I'm putting it inside the platelet right next to COX-1 because it actually irreversibly stops COX-1 from creating TXA, essentially. And when I say irreversibly, that means for as long as platelet number 1 lives, it will never be able to release TXA. So that's what ASA does. Okay, we have another class of medications, and they are called the P2Y12 inhibitors. And I'm drawing it, I'm writing it right next to a receptor because P2Y12 inhibitors like Clopidogrel actually block ADP from binding to its receptor. So it's not going to let another platelet get turned on. Clopidogrel is not going to let platelet number 2 get activated. So I'll highlight that. And now we have 2 medications to put under step 2 activation. ASA stops activation and Clopidogrel. So both these medications let adhesion happen. Adhesion has already happened. So we do have one platelet turned on, at least one platelet turned on, but these medications are not going to let the other platelets get turned on very well, or not very many platelets get turned on. So in that way, they don't let blood clots form. So that's step number 2 meds. Now let's go to step number 3. And you may have guessed step number 3 has to do with the GP2B3A receptors. And it's a class of drugs called GP2B3A inhibitors. So I'll highlight that because that's where those medications are working. So they are not letting fibrinogen bind to those receptors. An example drug in this class, and I'm going to put it under step 3 aggregation, is abciximab. Another medication is tirofiban. So both of these are GP2B3A inhibitors, and I'm listing them under step 3 aggregation because they don't let fibrinogen connect to those receptors, which means that the platelets can't connect to each other because that's the mechanism by which platelets connect to each other. In clinical practice, you are very likely to see meds like ASA and Clopidogrel. The receptor inhibitors, I have not seen too commonly in practice, but you might see them. Our next group of medications are medications that impact the clotting cascade, but I'm going to save that for another video. So let's just review what we learned about in this video. We started off by talking about what makes a person more likely to form a blood clot, and it's any component of Virchow's triad. It's any kind of endothelial injury, hypercoagulable state, or anytime that blood is sitting still. That's going to make the body start the process of getting to a stable clot. And it gets to a stable clot through a few different steps. Firstly, the first set of platelets, they adhere to the vessel wall. So that's step 1 adhesion. The platelets adhere to the vessel wall. Von Willebrand factor helps them do that, and they are actually activated by exposed collagen. So that first set of platelets, and in the diagram it's platelet number 1, it was actually activated by the exposed collagen and by the von Willebrands, and that's what made it adhere. Those activated set of platelets want to activate other platelets, and that's what step 2 is. It's those platelets stuck to the wall that are releasing TXA2 and ADP that call other platelets closer to them and say, hey, platelets, we have to stick together, and hey, you should also release TXA and ADP. That TXA and ADP also turns on a receptor complex called the GP2B3A complex, and then that's when aggregation happens. Fibrinogen binds to that receptor complex, and just so that we are really clear in what's happening with this fibrinogen bridge is what it's called. Right above step 3, I'm going to draw 2 platelets. Platelet number 1 and platelet number 2. And they've both been exposed to ADP, so they both have the receptor complexes on them, and they are both really motivated to bind fibrinogen. So because both sets of receptors are really motivated to bind fibrinogen, they're going to grab together. They're going to stick together with fibrinogen in between them. And that's why it's called a fibrinogen bridge. So now we have platelets that are really stuck together. That's what aggregation is. From fibrinogen, we can get to fibrin, and we can get to a fibrin mesh, and that's through the action of thrombin. And we need the clotting cascade to get thrombin. So now we have a stable clot. We've gone from a fibrinogen bridge to a fibrin mesh. We most definitely have a stable clot. If we wanted to take this one step further, we could get into retraction, which is the clot shrinks and the edges of the wounds draw together. I talked about an inherited disease, von Willebrand's disease, that basically people don't have as much von Willebrand's factor as they should. There's other meds, ASA, Clopidogrel, the receptor complex inhibitors that kind of stop this pathway in its tracks. In another video, I will talk about the clotting cascade, the medications of the clotting cascade, and also talk about our coagulation lab values and what they are and what they mean.